Welcome to the only patient advocate podcast you'll ever need. In this podcast, you'll learn how to advocate for yourself and your family, and where to turn when if that becomes overwhelming. Now, here's your host, Joyce Schulz-Killian, registered nurse and owner of At Your Request Patient Advocate, LLC. She is your private patient advocate. Here at your request to communicate, educate, and advocate with and for you.
Hi everyone, I'm Joyce Schulz-Killian, a registered nurse for 27 years and in healthcare since I was 18 years old. I'm the owner of At Your Request Patient Advocate, LLC. I'm here at your request because I am your private patient advocate, helping you navigate healthcare one puzzle piece at a time by educating, advocating, and communicating with and for you. I'm hoping to give you the tools you need to be your own best private advocate. Find me on Facebook at Your Request Patient Advocate, and on Instagram at JSKICURN, and on Twitter at RNAdvocate, the number 4, the letter U. So at RNAdvocate for you. Hit like and subscribe if you like what you hear, and tell a friend. Today's podcast should have been 2 weeks ago because we did discharge planning, and then I did care for the caregiver. So today, number 12 podcast is going to be preventing hospital readmissions. This was a presentation that lives tried and true for years. I did this presentation many years ago, and it took me about 10 minutes to update it to the current statistics and everything for 2020 and the years that have prevailed since I did the presentation first in 2015, 2016. So here we go. Preventing hospital readmissions. There's no place like home. So monitoring inpatient care and adherence to best practices when you get into the hospital is one of the things that I do. So every time somebody goes into the hospital for a certain condition, there's a certain set of guidelines that is there to guide the professionals of best practices and guidelines, and that the hospital is adhering to these evidence-based standards of care is very important. So if you come in with a heart attack, the nomenclature is the same as if you, everybody who comes in with a heart attack, everybody is treated the same way. They get an EKG, they get blood drawn, all these things are the same. So that's what I do when you're in the hospital is call to make sure that everything is happening the way it's supposed to. Discharged teaching. So now you've had your hospital stay. Everything's gone the way it's supposed to. And discharged teaching, which we've done a podcast on, is based on the needs of the patient, taking into consideration the way they learn. Don't tell me, show me are some of the things on my slide. Helping them when you set up their medication box to know what their medications are. That's very important. Cost of readmissions and dollars and cents. Readmissions cost an extraordinary amount of money. Unnecessary and preventable hospital admissions lead to an estimated $41 billion in additional hospital costs annually, according to the estimates from the Agency for Healthcare Research and Quality, AHRQ. More than 2,600 U.S. hospitals with readmission rates that are too high will see their Medicare payments docked up to 3% in the fiscal 2016 and moving forward for poor performance on the metric. That number is expected to rise as much as 6% as a hospital bases operating DRG by 2017. That did not happen. It remains at the 3% per CMS.gov. That was a Rice and Conlon article that I had in 2015. But the amounts have still stayed the same. They're still being penalized 3%. So what the hospitals did at that point is they created observation status. We're going to talk about that. So it says in assessing readmission readmission costs, the study found the mean cost per readmission to be $16,852, which amounts to approximately $3.5 billion in annual costs within the United States. Putting things into context, Dr. Gadre says the annual economic burden due to conditions for which hospital readmissions reduction program monitors readmissions is close to $7 billion. These conditions include heart failure, chronic obstruction pulmonary disease, so COPD, pneumonia, acute myocardial infection, sepsis, and now it contains total NIPS, total knees, and total hip surgeries. Yes, those are the main things. As a result, the Patient Protection and Affordable Care Act was established the Hospital Readmission Reduction Program, HRRP, to start penalizing hospitals for readmissions for select medical conditions under Medicare starting in 2012. So this has been going on for quite a long time, so 9 years now. And so they picked these several conditions, the acute heart failure, chronic obstructive pulmonary disease, pneumonia, acute MI, and sepsis, and now they've added total knees and total hips to the demographics to study. So what they saw was readmission rates with those patients. Within 30 days, somebody didn't do their job. So they created this HRRP program to start penalizing hospitals for those readmissions, saying that, well, if you've had the patient in the hospital and you sent them home, you discharged them with the appropriate discharge instructions, follow-up care, and they come back, you're responsible for that. So federal legislation could help address the problem of observation status for Medicare beneficiaries. Identical companion bills reintroduced in the House and Senate this month will take a different approach to instead of calling it an inpatient stay, because they couldn't identify what was an inpatient stay and what was not an inpatient stay based on where the hospital had the patient. So hospitals were keeping patients for 2 weeks on an observation status, and you wouldn't be admitted, and you didn't know that. You might be being kept in a regular hospital room up on a floor, but your status was observation, not fully admitted. To have the full rehab benefit, you need to have 3 overnight stays in a hospital as an admission. So people were staying for weeks on end, being treated for their congestive heart failure. They were on diuretics, or they would come back in for their pneumonia treatment and they would be placed back on antibiotics. But instead of admitting them, the hospital, knowing that they would be penalized, would put them in observation and then they would treat them. So the Medicare couldn't distinguish who was in observation and who was not based on their study, so they couldn't penalize. They weren't able to penalize. So it says another approach would be to remove the 3-day requirement altogether. So Senate is meeting to either call it, they're going to call it in-hospital stay. So instead of all time in the hospital towards the qualifying for the 3-day inpatient Medicare requirement. So it would be an inpatient stay, in-hospital stay, I mean. Instead of inpatient or admitted status, because the hospitals did what they always do. They found a way around the penalties. So let's understand the population at risk. Acute MI, anybody coming in with a heart attack, falls under this criteria. They're treated, there's a treatment protocol, and then they get discharged. If they come back because certain parts of the protocol weren't followed, somebody didn't do their job, the hospital isn't going to get paid. Chronic obstructive pulmonary disease, we see it a lot in our elderly patients. That is a broad term for a lot of different symptoms that people have in their lungs. Heart failure, if you're in heart failure, congestive heart failure, right-sided or left-sided, If you're in congestive heart failure, there's protocols that you should follow when you get home and you're discharged. One of them being the most important thing is to weigh yourself every day. I tell people on a good day, I can't gain 2 pounds at a buffet. If somebody were to weigh themselves every day and see a 2-pound weight gain, they could be on the phone with their doctor, calling, adjusting their medications if they're in heart failure, and preventing another hospitalization. Pneumonia. A lot of people, once they leave the hospital, for some reason don't follow the protocols. Maybe they don't continue to take their antibiotics, or they don't follow up, or their breathing, maybe home health doesn't show up for a couple days and they don't have their breathing incentive spirometer, and they're not doing their exercises, and they're laying down, and so the secretions are building back up, and then ultimately they would end up back in the hospital. Coronary artery bypass graft surgery, that was on the list before. Sepsis was a big one back in 2015. It was added to the list. And now the newest member of this elite group is total hip arthroplasty or total knee arthroplasty, because those are on a trajectory, and if people don't meet the requirements of the trajectory that they're on, and say, I've had hips that come home the next day after they're done with their surgery. They're getting up that night, they're walking in the morning, and they're coming home in the afternoon, and they're not going to rehab. So these are all new things. And if you have any comorbidities, then possibly you're being readmitted. Congestive heart failure. Congestive heart failure affects nearly 6 million Americans. It's the leading cause of hospitalization for people older than the age of 65. There's right-hearted heart failure, and there's left-sided heart failure. It affects roughly 670,000 people are diagnosed with heart failure every year. It is the leading cause of hospitalization in people over 65. There is no cure for congestive heart failure, but both right-sided heart failure and left-sided heart failure can be controlled and very manageable. COPD, it affects 24 million people per year. It is emphysema. Oops, let's not do that. It's emphysema, chronic bronchitis, refractory non-reversible asthma, some forms of bronchiectasis. So it combines a whole lot of different pulmonary diseases, causes shortness of breath, shallow breathing, tense muscles. People get anxious when they can't breathe, causes worsening shortness of breath, limits your activities, makes you get more anxious, again causes shortness of breath. This is a vicious circle. Heart attacks are another one of the readmissions. Blockages of a coronary artery cause death of the heart muscle if not treated immediately to open up the blockage. That's a heart attack. So there is a protocol. It's the number one cause of death in the world and leading cause of death in the U.S., killing 375,000 Americans every year. Better immediate treatment options like cardiac catheterization and intervention to open blockages allow people to live and be able to leave the hospital. These are some of the stroke and cardiac issues, are some of the timely issues that you need to get to the hospital for. Breathing, people tend to come in quickly. You're having a heart attack, chest pain, they're thinking, oh, it's just indigestion or nausea, but most of the time it is not. So don't wait. There's a limited amount of time that they can do some interventions if you are having a stroke or a heart attack. Pneumonia. Bacterial or viral infection that inflames air sacs in one or both of the lungs, which may fill with fluid. Pneumonia is very treatable. It is caused by bacteria or a virus, and it can be treated with antibiotics and bronchodilators. Antivirals, and bronchodilators. Sepsis. Sepsis is the body's overwhelming and life-threatening response to an infection which can lead to tissue damage, organ failure, and death. Sepsis accounts for as many readmissions and deaths as heart attacks and congestive heart failure combined, both of which are monitored closely by the Affordable Care Act. It costs twice as much to treat as the other two other two combined, research has shown. For a 30-day readmission, sepsis accounted for 23%, one of the most... Where are my notes? How come I can't see them? One of the most striking findings was that readmissions within 30 days after a sepsis discharge were quite common and affected approximately 1 in 5 patients. That's 20% of the patients come back if they've had sepsis. That's poor management at home. Not a good follow-up with home health. Somebody is not doing their job. And then the last one, the newest ones on the list, are the total knee and total hip arthroplasties, which are on a trajectory of, like I say, the trajectory for total hips and total knees is really low right now. People are getting out of the hospital very quickly from knees and hips. They're not going to rehab. They're going home. So these are all the things. Preventing hospital readmissions. So how do we do that? Comorbidities play a role in readmission rates and deaths. Of elderly patients dying within 30 days of admission to the hospital, approximately 1/2 die after discharge from the hospital. Comorbidities in general were equally associated with death in the hospital or death after discharge. We found that a lot of the patients were readmitted with comorbid conditions such as heart failure or acute kidney injury that would potentially be addressed if they were in the inpatient setting. The study also identified several predictors associated with increased 30-day admissions, such as diabetes, chronic kidney disease, and congestive heart failure. So all those things need to be monitored very closely when you get out of the hospital, if you have any of those comorbidities. A few more statistics. 30-day readmission rate for heart failure hospitalization was at 24%. 30-day readmission rate after a heart attack in the hospital was 20%. 30-day readmission rate after a pneumonia hospitalization was 18%. Respiratory disease accounts for 40% of readmissions. Total knee and hips account for about 15% of readmissions, and majority of all readmissions occur within 11 days of being discharged from the hospital. So now here are some proven ways to prevent going back. So be there when needed. There's one simple thing that we can do that we often don't do, said Diane Omdahl, RN, co-founder of 65 Incorporated, an organization helping seniors understand Medicare, and that's to see the patients on the same day as discharge. When my patients are in the hospital and they go home, I go to their home the day of discharge to look at the papers if I'm not picking them up from the hospital and taking them home. And being part of that medical reconciliation at the end there. I take them home, or if I'm not, I'm meeting them at home that day, later that same day, to go over those discharge papers to make sure that we have all of our follow-up appointments made. And all of those things done. There is no place like home. That ensures a smooth transition of care. We look at what's the plan, and we don't wait around. We review the doctor orders, limitations that were given. We review the medications. We set up the med boxes. We make follow-up appointments, and we're adamant about making those follow-up appointments that we're out of the hospital, and we need the appointment within a certain amount of time. Don't let them put you off 3-4 weeks. You can't afford to do that. Teach the disease process. If it's congestive heart failure or an MI or something like that, I'm telling the patients, congestive heart failure, I'm teaching them you have to weigh yourself every day. Teach the disease treatment. I'm treating how the disease is treating. Contact and teaching based on need, daily if necessary. I'm calling patients sometimes in the evenings to remind them to take their pills. I'm calling them sometimes in the morning to ask them if they've weighed themselves yet. Daily check-ins, front-loading care for certain groups. The elderly, I front-load my care. So I'm in there a lot in the beginning, and then towards the end, I can relax because they've got it all. Coordination between hospital discharges and physician follow-ups, making those appointments, calling those doctors, insisting that you get in within a timely manner, not 2 or 3 weeks later. Discharge from the hospital constitutes a visit to your doctor within a week. Sometimes they'll say follow up within 1 week, 2 weeks. So when you're calling, make sure that they know that. Medication management and education. I'm doing that with my patients. I'm giving them the tools to take control of their care. I'm giving them a daily sheet to put their weights on. I'm leaving it in the bathroom by their scale. I'm giving them a notebook to record all their symptoms in. I'm bringing them a med box if I need to. We're making checklists and going through those checklists, checking them once and checking them twice. Knowledge, giving them the knowledge to call me when there's a weight gain of 2 pounds or 5 in a day or 5 pounds in a week, so medications can be adjusted by the doctor. I'm writing their appointments in a calendar largely enough so that they can see them. Now, beware of observation status as opposed to admission. You lose Med A rehab, availability increase, the out-of-pocket cost for the patient. So there was a bill a long time ago, HR 1571, that supported Medicare recognizing observation days towards the admission stay in the hospital. I was encouraging people back then to write your congressman. That bill failed. So hospitals are not reimbursed if you come back within 30 days. So they don't want to admit you with the same diagnosis. It means somebody didn't do their job. So you're not going to get admitted. You're going to be put in this observation status, and then that's going to really negate your ability to get rehab afterwards. So now, right now in Congress, they're doing an in-hospital stay. If you've come back to the hospital and you're in the hospital within 30 days of being in the hospital before, then they're going to try to count that. That seems, healthcare is so much different now than it was in 1965 when all of this was created. And again, the hospital system is so good that instead of being penalized, they found a way around it. So that's my spiel on hospital readmissions. I get into a home the day of that the person comes. I just recently got a new client and met him at home when he got there, made sure, and he just was Johnny on the spot. He had made all the appointments prior to leaving the hospital, which should be done. So everything was done. He had all of the medications he needed. He had everything he needed to take care of what he needed to at home. So everything was done. It took me 10 minutes at his house and I was able to leave. That's a good discharge plan. So that's my spiel on discharge planning. You're not returning to the hospital within 30 days. If you have any questions, give me a call or text me at 847-809-1214. I'm here to answer your questions. And on that note, I would like to thank you all for listening. If you like what you hear, please hit like and subscribe and tell your friends. I would like to thank everyone who has helped me take the plunge into this podcast with all my dreams I've had in the past 8 years. Thank you so much. Remember, I am your private patient advocate, and I'm here at your request to help you navigate the healthcare system one puzzle piece at a time by educating, advocating, and communicating with and for you. I'm here at your request because I am your private patient advocate. Find me on Facebook at your request patient advocate, and on Instagram at JSKICURN, and on Twitter at RN Advocate for you, the number 4 and the letter U. Hit like and subscribe and tell a friend. And I'm also on YouTube at Request an Advocate. So find me and like me, and hopefully you lasted through this clunky podcast.